Dr. Mohammed Ajyebo, got that right this time, right? Who's a Ph.D. He's originally from Gambia. Dr. Mohammed Ajyebo traveled to the United States where he received his bachelor degree in cellular biology from Berea College. He went on to complete a Ph.D. in microbiology and immunology at Vanderbilt University. His current work in molecular virology, I'm going to get through this yet. Focuses on designing a vaccine for HIV. As well, Dr. Ajyebo is working to model the Ebola virus to identify therapeutic targets. His interest is in global health and infectious diseases, and he plans to work in program implementation, discovering innovative ways to provide care in Western African countries. So, no further ado, the two doctors. Beautiful. Thank you so much.
Thank you very much for having us this afternoon and for inviting us again to talk to you about Ebola. And we'll today provide some information, some basic information about Ebola, and try to dispel some of the myths that we hear, or from friends, from the media, and hopefully give you a better layout of the reality of the situation with Ebola as we are dealing with it. I will give you a brief history and background about Ebola and where we are now and what we're doing about it. Ashira will talk about how we got here in the first place. All right, so Ebola first appeared in 1976 in South Sudan in a small town called Nzada. And that was the first recorded outbreak of Ebola. And for that particular outbreak, about 150 people died. And this was in June. 2 months later, almost concurrently, in a small village called Ajyebo in the Democratic Republic of Congo that lies just along this little river here. And the river is called the Ebola River, and that's where Ebola got its name. And for that particular outbreak, about maybe 280 people died. But that's really what brought Ebola to the forefront at that time, because one of the things that was observed was the mortality rate. So 90% of people who were infected with Ebola in that particular outbreak died. So that was something that wasn't previously observed, and it was a thing that brought Ebola to the forefront. Now, that's where Ebola was first, documented in that particular fashion. So where does it actually come from? Fruit bats. Bats are notorious reservoirs for all sorts of viruses. For some reason, they're able to host all these viruses and they don't get sick themselves. And so they're fantastic reservoirs for all kinds of pathogens. And in the case of Ebola, it is believed that that's where the actual virus originated from. And it's transmitted by when they eat fruits and drop it on the ground. Chimpanzees, gorillas, antelopes forage on the ground and eat this. Now, when the bats are eating these fruits, they release some saliva into the fruits, and the saliva contains viruses, which are transferred to the fruits, and the animals consume them, and that's how the animals themselves get infected. Now, these animals are hunted by humans for food. So when they handle the meat from it, when they consume it, that's how humans get it from animals. And then from then on, it's transmitted from human to human via contact. So the disease cause for Ebola is actually very interesting in terms of how it spreads. For the first 7 days that you're exposed to Ebola, you probably are asymptomatic. So you don't know, you don't feel sick at all, and you feel fine. And during these 7 days, during this stage where you're asymptomatic, you are not contagious. I mean, you can come in contact with anybody or anything, and you cannot infect them during that first 7 days where you don't feel any symptoms. Now, after that first week, when you start showing symptoms of headaches, fever, chills, muscle aches, weakness, once your symptoms start to show. This is usually a week after exposure. So if you follow this arrow, I don't know if you can see it behind me, by the time you get around to the second week, this is where the damage actually starts to happen. And this is where you get gastrointestinal symptoms. So a lot of diarrhea, very severe diarrhea, you get vomiting, a lot of abdominal pain, rashes, your eyes start to red from the hemorrhage. It is actually this part of it that does most of the damage to your body. And if you don't recover within, say, the first 6 days after you start showing symptoms, chances are you will not make it back. So probably maybe after 2 weeks, around 16, 17 days, then you start having your blood vessels being damaged, you start having organ failure, and that's when you see the bleeding. But by that time, the diarrhea is actually what is the most severe symptom of this disease. And as you progress through this curve, the more red you see, the more contagious you get. So in the beginning, the first 7 days, you can be infected and you can infect anybody else. But by the time you go through the course of the disease over 3 weeks, for most people will end up dying. But those are the times when they are most contagious, even after when they're dead. So that's why you see people with burial practices. There was a big concern during the whole Ebola crisis in terms of transmittability. People can still get infected, handling dead people, people that have succumbed to the disease. However, it's not a very contagious virus. And in this particular outbreak, one person that's infected will actually infect, like, at most maybe 2 more people. And I want to clarify something here, the difference between infectious and contagious. For the most part, when you hear this in the media, they use them interchangeably as if it's the same thing, but it's not really the same thing. So when we say something is contagious, it talks about, or refers to how easily it spreads from one person to another. Say, if you have one person, how many other people can you infect from that one person? And if you see in this image here, Ebola is way over here to the left. As you go to the right, the more contagious you are as a disease. HIV, you can infect 4 more people. If you are one person, will infect 4 more people in general. And up to measles, which is very contagious, but you can also, so you can infect up to 20 people, 18 people from one person. Now, when we say infectious, it means how much of it do you need to be exposed to get sick, right? So it's not about spreading, it's how much you get exposed or how much do you need of it exposed to get sick from it. And Ebola, in this case, is very infectious. So once you get contact, you're going to get sick no matter how little the contact. So that's the difference between infectious and contagious. Now, Ashira will talk about why, even though it's not contagious, it still spread and we had an outbreak. In the meantime, since 1976, up to this outbreak that started almost a year now, there have been about 20 different outbreaks all over Africa, mostly in the equatorial part of Africa. And what you will see is that over the past 40 years, throughout these 20 outbreaks, a total of just over 1,000 people have died from Ebola. Total, over 40 years. Now, what is different about this current outbreak, and I'll touch on it on the next slide, but where is it coming from and how is it different? So we believe that the patient zero, or the initial person who got first infected that started this outbreak, is like a 2-year-old boy in the Gekedu region in Guinea. And he started showing symptoms around Christmas time, maybe day after Christmas or so, and he didn't make it to see the New Year's. He died a few days afterwards, before the turn of the New Year. And over the subsequent weeks, the family members, the health workers that were helping them out also started dying. And now, over the next 3 months, it spread slowly and slowly, and eventually it's what became this whole big epidemic. However, there's no way we can definitely confirm that they are all linked to that one war. So where are we today? Even though it's not in the news, Ebola is still going on. And right now we have almost 25,000 cases of Ebola in Guinea, Liberia, and Sierra Leone. And these are suspected probable cases, some of them are confirmed. But as far as confirmed cases, we have almost 15,000. And out of those 15,000, 10,000 people have died. Now the interesting thing you may notice here is that it all started in Guinea, but Guinea has the least amount of deaths, right? And Sierra Leone, which was probably the last to catch on, ended up having the most amount of confirmed cases, like 8,500 almost. And it's still the case that as of today or as of last week, Sierra Leone still has the highest amount of cases, and they're still seeing infection rates. While it's stabilized a little bit, there's still new infections every week in both Guinea and Sierra Leone. Now, we've had some successes in Nigeria, Senegal, Spain, United States, where we've seen a few cases of Ebola, and we're fortunate to be able to prevent an outbreak in a country like Nigeria, which has over 100 million people. Something like Ebola breaking out there would have been devastating. But luckily enough, they were able to control it, and only 8 people died. And as of last year, in October, Nigeria, Senegal, Mali were all declared Ebola-free. And to be declared Ebola-free, you shouldn't see any new cases. The last person has to be treated, and 42 days after that, if they don't see any new cases, then you can declare a country or region to be Ebola-free. So, wonderful news. As of last Friday, this is the second week where there are no new reported cases of Ebola in Liberia. So that is absolutely fantastic news. So, now throughout this, women, of course, are seen to be the most affected by the Ebola outbreak. And almost 60% of the victims that die from Ebola are actually women. And in Liberia, it's actually 75%. And the reason for this is the cultural expectations in this region, in these countries. Women are the primary caregivers. You know, they're the moms, they cook, they bathe, they feed. If you're sick, your mom take care of you. You know, the husbands, the children, everybody, it falls on the woman. And that, what happens is that there's a higher risk of exposure because of their involvement in that. And they're also very much involved in the burial rituals, where I told you that even when people die from Ebola, they can still infect other people. So women, since being heavily involved in the burial rituals, also expose themselves. And even in the front lines, most of the nurses that are in the treatment centers are women. Most of the birth attendants, women may or may not be infected with Ebola. You know, it's women that deliver the babies. You know, they're the cleaners, they do the laundry work, you know, the hospitals, and they do most of that work, and all of that material is contagious material, and they can get exposed and they can get infected from Ebola from that. And the other thing is that they're also traders. You know, they do a lot of weekly markets, they go and sell their produce, they have their little farms, they have their cooperatives, and crossing the borders back and forth, especially in Guinea, Liberia, Sierra Leone, where it's like contiguous, they share a border, and as they move back and forth, it increases their risk of exposure. And now, the subsequent burden of Ebola outbreak in most of these countries where the public health infrastructure now is just badly damaged, because so many people are sick and they don't have enough doctors, they don't have enough resources to take care of them, is that pregnant women don't have enough access to maternal health care, reproductive health, and this affects their kids as well, because the health infrastructure is also just so burdened. Now, what are we doing to try to slow this down and stop it? Right now, there's like 3 levels that you can approach this. The first one, which is the most important one in my opinion, is vaccines. And not just because I design vaccines for a living, but, but vaccines have a tremendous value. And right now there are 2 lead candidates, one of which started the trials, phase 3 trials. So when you do phase 3 trials, it's when you do a large-scale study to try to figure out how effective the vaccine is. There's a few more in development, and there's a few more in phase 1 trials. So phase 1 only deals with how safe the vaccine is. Is it safe to give it to people? So it's generally administered with a small number of people before you go to phase 3. Make sure it's safe, and then you go to phase 2, a little bit bigger number of people, and then finally a big, large scale, which will eventually lead to hopefully something that we can give to people. The next one is therapies. So we have convalescent blood plasma from people that have already been infected with Ebola but recovered. So their blood has antibodies that have helped them fight off Ebola, and we can collect this and give it to people that have Ebola and see if that will help them. There's also a couple of medications, favipiravir, Incovarid, and ZMapp, and these are actually were made for different viruses, but they're trying them to see if they will be effective against Ebola. The other issue is diagnostics. So what that means is, how do you determine if somebody that comes in sick with a lot of symptoms, if they have Ebola? Right now, it takes almost from half a day to 4 days to determine if a person has Ebola or not, to see what kind of treatment or what kind of help you can give them. And that is just too much long of a time. So now there's a big push to have rapid diagnostics where you can determine if you come in contact with somebody, you can determine within an hour, 30 minutes, if this person has Ebola or not. And you can imagine how quickly you can move them to an isolation unit, to a treatment center, and know how to proceed with treatment. And now this is where we are. So there's a lot of hope, and there's a lot of push towards trying to curb this outbreak. And now Ashira will talk to you guys about how we got here.
Okay. Very good. So, how did we get here and where are we now? So, you may have been paying attention when Mohammed was talking, saying that, one person with Ebola is only expected to infect 2 other people. And so from there, how did we get to this massive outbreak, 25,000 people having Ebola in these affected countries? And so when you look at these case per week curves, so this is how many cases in each single week were diagnosed. Potentially the most shocking thing that you're seeing is that in the height of the epidemic, especially in Sierra Leone, 600 people every week were getting diagnosed. But one of the more interesting things about this graph is that we started counting cases here in March 22nd of 2014. Now, the patient 0, the first patient who we think got infected, this 2-year-old boy, was actually infected December 2013. And so, as you might expect, if an epidemic is going on for 4 months before anyone ever reports it to the health ministry, it's gotten its fuel before we even start to respond. And so lack of vigilance was really a culprit for this large outbreak. And so you can see here, so by March 22nd, when the Ministry of Health in Guinea was informed about this outbreak, there had been 80 cases already, 59 deaths. 4 villages were involved, including 2 cases reported in Liberia. And so early in the epidemic, people were getting sick, and the communities knew that. And so, patients would travel across the border because in Liberia, there was a traditional healer who was said to be able to cure Ebola. And so before any of the health ministries knew, before any of the organized healthcare knew about this, people in communities already knew and were starting to spread this disease. Okay, and so the WHO mentions that this really is an epidemic with 2 causes. So the first is, of course, Ebola is a very unforgiving virus. It is gruesome, it causes, awful sequelae, and it's difficult for people to survive. The second is that there was so much fear, misunderstanding, and mistrust in a place that was poor in infrastructure, that this fueled how terrible this epidemic became. Okay, and so what do we mean by poor health infrastructure? So it's quite an opportune that Ebola affected these particular West African countries. And so in the 1990s, before, when the HIV epidemic was in Africa, it was more in East and Southern Africa. And so in those places, aid poured in, and the infrastructure, the health infrastructure, started to build. However, West Africa, which was recently spared by the HIV/AIDS epidemic, didn't have these resources. And so, hospitals, health facilities weren't really there. And in fact, these countries were torn by war. And so this is one of the reasons why Voices of African Mothers work is so important, why Nana's work is so important, because, building health infrastructure in these countries allows the countries to withstand something like an Ebola epidemic. So the next time it happens, they're prepared. And so, really making sure that there's infrastructure and these violent attacks aren't going on is going to be paramount to preventing such a catastrophe in the future. And so I have here a few pictures of the facilities where patients are being taken care of. And so here you see this is an Ebola treatment center, and this is the inside. So expect that if patients there had a disorder that caused nausea, vomiting, you wouldn't be able to contain it very well, right? Disposal of garments, disposal of waste materials, quarantine of patients just isn't going to happen in a facility like this. The electricity is very unreliable. As Mohammed was saying, diagnostic laboratory testing is already too slow in a place with good health infrastructure. So if infrastructure is in place, you can expect to have the test back in a half a day to 4 days. Imagine this happening in a place that is remote, in a village without good electricity, without laboratory testing. You could be waiting an extended period of time to even know whether or not somebody is infected. And so all of these things contribute to the severity of this particular epidemic. So, and this is why we have such a disparity in the case fatality rate. So in the Western world, there have been about 26 cases. This is going to increase here if you guys have been reading the news. There are 10 cases coming over. However, 26 confirmed cases, and about 23% of those patients have died. And that is because, as Mohammed was saying earlier, the real culprit for deaths in this epidemic is the diarrhea and the vomiting. So the same as we've seen in E. coli outbreaks or typhoid fever outbreaks, when patients become dehydrated, they need access to clean water, they need access to supportive care. And this just doesn't happen in a country without health infrastructure. And so we see, in the Western world, we have this, survival rates are actually fair. Compared to developing world, where 41% of the 25,000 cases have succumbed to the disease. And this figure sort of gives a skewed view because this includes patients who either didn't have the diarrhea and had the diarrhea. So these are all comers. So in patients who had the gastrointestinal disease, the mortality rate is about 70 to 80%, so staggering. And that reflects the lack of supportive care, the lack of clean water, the lack of ability to care for these patients in the most basic of ways. So I show this figure actually because it illustrated to me my own lack of cultural competence. So I saw this and I thought, this is the problem, right? Here in the United States, we have 245 doctors per 100,000 people. And then, Liberia and Sierra Leone, Guinea, the best you can hope for is 10. And so, as a Western doctor, I like to feel very important. And so I thought to myself, there's the problem, they don't have enough of me. And how could anyone ever get better in that situation? Well, the problem is the health structure there. And so actually there's one traditional healer per 500 people in the general population in these West African countries. And we think if you get sick, you get diarrhea, fever, anything like that, you would go to a Western doctor. There, you would go to a traditional healer. And so the problem with the response initially is that these people really were not engaged. We in the West think, well, if they're not, doctors as we see them, there must be nobody taking care of the population. And so we sort of disregarded the infrastructure that was already in place. And so, think about if there was a horrible epidemic in the United States, and our medical system wasn't taking care of it very well, and a group of traditional healers from Guinea came over and they said, don't worry, we know how to take care of this. Leave your primary care doctors, leave your hospitals, come to us, and we will take care of you. How many people would be on board for that? No, right? If your doctor said, these people aren't really, what I would expect were able to help you, you would trust your doctor, right? Because you know your doctor. That's the person who heals you. And so to not engage the traditional healers in this effort was really a failure on the part of the response. And not only this, these traditional healers are often local religious leaders. They're well regarded in their communities, and they're the first ones to know when there are new cases. And so the ability to really pick up on the new cases, to track them effectively, is contingent upon engaging these cultures appropriately. And the other issue was, the Stop Ebola campaign was based on TV ads and radio ads and, in remote villages. Probably not the best way to reach people. It's all very word of mouth. And so, again, you would have to be able to engage these cultures appropriately in order to effectively make a response. Okay, and so we've learned this. And this new way of dealing with the epidemic has actually been effective. And so, we've seen in Liberia over 2 weeks now with no new cases, which is a huge success story. And it's because the Western world and the developing world, the West African cultures, are working together in a more appropriate way. And so there's been engagement of community leaders. There's been mobile and emergency response. And so, initially in the response, it was expected that someone who was infected with Ebola would come from their remote village to, one of the urban areas, and seek treatment. So, that would be difficult if you didn't have Ebola, right? Imagine having fever, having diarrhea, being sick, and then having to travel to an urban area just to seek treatment. It was not very feasible. However, now that the U.S. Army has sent troops, and there are more people with more resources, as soon as they hear from a community leader, hey, there's an Ebola outbreak here, they're able to deploy and set up mobile camps in the area where people are affected. And this has been quite instrumental in helping to control this outbreak. And again, because there's buy-in from the culture, that people are able to tell whether or not there are new cases. Okay, and so now that the Ebola is starting to shift, the WHO says that we're in phase 2 of the epidemic. The new target is 0 new cases. And so what does that mean for the people who have lived through the worst of the epidemic, hopefully the worst of the epidemic, and what do we need to do now? So, of course, being a survivor comes with some challenges. Just in Sierra Leone alone, there are some 2,000 people who have actually lived through Ebola. And so in a place where many people live in community with others, live on compounds or live with their extended family or friends, having stigma, having people being afraid that you might infect them can come with quite a cost. So people are being sent out from their former communities. There's joblessness because they don't want these people to go back to work and potentially infect those at work. There are issues with homelessness, and actually survivors are creating rescue teams, and so they're coming together to form their own communities to advocate for survivors who are either illiterate or don't have access to homes or jobs, and they're coming together to make their own communities. And so this is within the culture a way for people to live past this epidemic. So the other issue is that there are so many orphans. So there are over 10,000 orphans now created by this epidemic. And of course we saw this with the HIV/AIDS epidemic, but the difference there was that, no one expected the kids to transmit HIV/AIDS to their new families. And so, if a child has been in contact with somebody who's been infected with Ebola, not only do you not know whether or not the child is infectious for a good week or maybe even more, but also, kids don't play by the rules. Kids are not going to wash their hands. Kids are not going to dispose of diarrhea appropriately. And so they're thought to be, these orphans are thought to be quite dangerous to take in. And so the effort has been to have group homes for these orphans. But unfortunately, this is feeding into the human trafficking business because there are so few adults with good intentions looking to take care of the children. And so this is a really big place where we need to focus our efforts as we move past this epidemic. And so, how are we doing on time? Okay. Okay, all right. I will be fast. Alrighty, so Ebola relief funding. So there's been actually a fair amount of funds, about $2.3 billion pledged to Ebola relief, which is wonderful. Unfortunately, as you can see, there can be a difference between what is pledged and what is actually given. And so a fair number of these funds have not actually been dispersed. However, the international community is committed to improving the state of these countries who are affected. So this just shows that there's still quite a bit of a gap in the funds that are available and the funds that are required. And so this is just from January to June, the budget for Ebola relief, and about $102 million have been pledged. However, during the same time period, it's estimated that $370 million would be necessary to really combat this epidemic. And so there's still great need for donation. There's still great need for support in these nations. And so there's so many economic consequences of the Ebola outbreak. I think we all think about, human loss without necessarily thinking about what this does to the economies, the local economies, and even the international economies. And so, the tourist industry has greatly suffered. There's very few tourists going over to these countries and pouring money into the economy as there was prior to the epidemic. Many schools and businesses have closed. Here, this is in Sierra Leone. You can see this used to be a thriving marketplace, and the entire place has been closed. And so there's this great period, over a year and a half period of lost revenue just from this epidemic alone. And as we alluded to earlier, health services have basically collapsed in these areas because prior to the epidemic, there were some health services, but now that the hospitals have been overwhelmed by Ebola patients, not only are people who don't have Ebola less likely to get care there, but also being able to disinfect the facilities and make sure they're safe for use afterwards has been difficult. Okay. And so there are a number of different strategies that we've sort of alluded to. But being able to set up research, more strategic emergency response, engaging the community and preventing spread to unaffected countries are some of the main focuses moving forward. And these are places where you can donate to help for